Hello everyone, welcome back. Today I'll be covering regarding the overview of the hip pain in children. This video is especially dedicated for the medical student and is a part of revision for the master student in orthopedics. Now let's get started. Introduction. The rapid diagnosis of hip pain is important to rule out joint or bone infection. If left undiagnosed, it may lead to joint destruction. Differential diagnosis of acute hip pain in children include 1. Infection, 2. Inflammatory cause, 3. Mechanical or orthopedic causes, 4. Neoplastic or infiltrative cause, and 5. Others. Example of differential diagnosis of acute hip pain in children. 1. Infectious causes include septic arthritis of the hip, osteomyelitis of the femoral head or pelvis, Lyme disease. The referred pain can come from psoas abscess, septic arthritis of the sacroiliac joint, appendicitis, or abdominal or pelvic abscesses. Number 2. Inflammatory causes include transient synovitis, systemic arthritis. That include spondyloarthropathy, Kawasaki disease, infectious or post-infectious, idiopathic chondrolysis of the hip. Number 3. Mechanical or orthopedic causes include slip capital femoral epiphysis SCFE, avascular necrosis or leg calf Perthes disease or secondary avascular necrosis, femoral stress fracture, muscular strain. Number 4. Neoplastic or infiltrative causes include osteoid osteoma, leukemia, primary solid tumor, pigmented villonodular synovitis. Number 5. Others include sickle cell pain crisis. Important history to be known. 1. Duration of symptoms. Acute symptoms more suggestive of trauma or infection. Number 2. Any history of fever. Number 3. Any recent viral illness. Number 4. Any previous trauma. Number 5. Any knee pain. Usually this is a referred pain. Number 6. Any underlying medical condition. Example, sickle cell disease, rickets, SLE, systemic lupus erythematosus, patient on medication, example, especially steroids. 7. Any family history of hip disease. 8. Previous tick exposure. 9. Any history of red flag symptom, example, loss of weight, loss of appetite, pain at night, lethargy, bowel disturbances. For physical examination, 1. Ask the patient to walk if patient able to and observe the gait. Number 2. Ask the patient to lie down and check for any LLD, limb length discrepancy. Number 3. Any presence of muscle wasting that suggests a chronic disuse or illness. Number 4. Any point tenderness or evidence of joint swelling. Number 5. Range of movement of the hip, ROM. And lastly, 6. Examine the back. For diagnostic studies, additional information to help confirm the diagnosis. Number 1. If acute process is suspected, total white cell with differential count, ESR, erythrocyte sedimentation rate, the CRP, C-reactive protein, blood culture, arthrosynthesis for synovial fluid gram stain, and culture and sensitivity. Number 2. Chronic or insidious onset, the CRP and ESR. It helps to differentiate between the inflammatory and non-inflammatory disease. Patient can present with anemia, leukopenia, or thrombocytopenia that may suggest underlying chronic illnesses, especially malignancy. Lung serology in the appropriate epidemiologic setting. Number 3. Radiographic evaluation, especially in patients suspected to have septic arthritis, skeletal injury, or tumor. A. Plain radiograph for any bone abnormalities, example trauma, tumors, Legg, Calve, Perthes disease, slip capital femoral epiphysis, SCFE. B. Ultrasound identifies small joint effusions and is used when the plain radiographs are normal but the suspicion of septic arthritis or transient synovitis is there. C. Bone scan can differentiate septic arthritis or transient synovitis from osteomyelitis. In more chronic case, it can be used to identify avascular necrosis or Legg Calve Perthes disease earlier in the course than a plain radiograph. Bone scan can also help to diagnose tumor. D. MRI and CT scan is used to find reason of hip pain when other modalities have not been helpful or to provide more detail on an abnormality that already identified. Common etiologies. Number 1. Septic hip joint. Rapid diagnosis is important because increased pressure within the joint may lead to decreased blood supply to the femoral head. Majority of the children are less than 4 years old. They present with acute onset of fever, pain, epiphysis, refusal to stand or limping. Infants may present with irritability and poor feeding. Hip is usually in flexed and abducted position because this will reduce the pain. Diagnosis is by clinical suspicion, physical findings, and radiological changes with widening of the joint space and obtaining a culture from joint aspiration. The fluid will have low glucose, more than 50,000 white blood cells, and predominant polymorphonuclear. Gram stain and culture positive in 80% of cases. The blood culture positive in 20% of cases. There would be a risk in the white blood cell count, the ESR, and C-reactive protein. Treatment for septic hip joint is surgical drainage and antibiotics to cover the common organism, usually the Staph aureus. Number 2. Osteomyelitis. Patient may have previous history of trauma. The proximal femur is the most common site. Patient will present with fever and epiphysis, limping or refusal to stand, and there is a point tenderness. There will be increase in the white blood cell count, ESR, and C-reactive protein. The diagnosis is by radiograph, bone scan, and culture. Bone scan has the advantage of detecting multifocal disease, which occur in 7% of cases of pediatric osteomyelitis, usually in neonates. Again, the most common organism is Staphylococcus aureus. Number 3, transient synovitis, or also known as toxic synovitis. Most common occur between the age of 2 to 8 years old. It is a benign condition with the presence of small amount of fluid in the joint. It often follows the viral illnesses around 32 to 50% of cases. Etiology is speculated to be post-infectious reactive arthritis, but you need to rule out bacterial infection. The child may refuse to stand and limping. Pain on range of movement. Child is well, absent or low-grade fever. Septic parameters are usually normal or slightly elevated. The radiographs are normal, or there might be a small effusion that is not easily detected. Fluid aspiration is usually sterile. Symptoms may affect both of the hip, around 5% of cases. In symptomatic unilateral disease, ultrasound can detect bilateral effusion in 25% of children. The recurrent rates are 4 to 15%. The treatment is reassurance and follow-up throughout septic process, analgesic, and rest as needed. Usually, they will last for a few days. 1 to 2% will progress to Perthes disease with avascular necrosis of the ipsilateral femoral head. Number 4, slip capital femoral epiphysis, SCFE. More predominant in the male, common around age 10 to 16 years old, may be bilateral and presents at different times. This is a fracture of the growth plate leading to a slipping, usually posteriorly, of the femoral epiphysis of the femoral neck. Patient is often overweight and there is an association with hypothyroidism and renal disease. Patient will usually complain of pain at the hip or knee, usually referred pain, the knee, and holds the extremity in externally rotated position. They will resist internal rotation. The radiograph will be positive. The femoral head is displaced medially in relation to the femoral neck. The treatment is always surgical intervention with pinning of the femoral neck. Number 5, regarding left calf, Perthes disease, also known as avascular necrosis of the femoral head, commonly occur at the age of 3 to 12 years old. The mean is around 7 years old. More in male, 10% are bilateral. Insidious onset with painless limb, pain of the hip, groin, lateral thigh or knee pain. Physical examination will show limb length discrepancy, decreased abduction, and internal rotation. Radiographic is usually diagnosis when you see a flattening and fragmentation of the femoral head. Treatment is usually supervised neglect or controlled collapse of the femoral head. And finally, regarding osteoid osteoma. Number 6 is a benign bone tumor common in the femur and tibia prior to adolescence. Patients usually have pain worse at night, respond well to aspirin or NSAIDs, non-steroidal anti-inflammatory drugs. Failure to respond to medication usually rule out the diagnosis. Patient may require CT scan or bone scan to confirm the diagnosis. The management include excisional biopsy plus or minus radiofrequency ablation. Yay! We have reached to the end of this video. I hope you have learned something from this video. See you in the next one. Take care and bye.